Hi, Dan Zachary with the Fits on the Go.
Hi. Thanks for grabbing us.
Are you a fellow or like a professional interviewer? You just have that, vibe about you. It's great.
So, thank you. Tell me something about how you enjoyed the meeting this time.
Well, definitely. I mean, the venue is unbelievable. I think the ACC did a fantastic job. This pavilion right behind us is so beautiful, the way they set it up, and San Diego's been fantastic. And then let's also talk about the science, which has been great.
Absolutely.
So, Roxana, you want
Well,
to start?
great science. You actually just caught us because we were kind of talking about the BEST trial that was just presented, published simultaneously in the New England Journal. It was everolimus eluting stents versus bypass surgery, and they only enrolled half of the patients that they were supposed to enroll. So it's a really tough study. So we were going back and forth. I mean, it's nice that it's in the New England Journal, but we were kind of thinking that we still need a definitive trial and that we don't have answers. And what was interesting is that simultaneously there's a meta-analysis, which I think when I heard, I haven't read it yet, but
not the meta-analysis.
did you read the
Yeah, I read
meta-analysis?
it. It's actually,
what is it?
No, so it's a study done by Shripal Bangalore, Ed Hannon. They took the New York State database and did a propensity-matched analysis of EES patients and bypass surgery. I mean, it's a really important question because Syntax was done with older stents a while back, and a lot of people have said, well, if we use the current generation's DES, such as EES, maybe that'll mitigate the differences between bypass surgery and PCI. Certainly in the standpoint of death, MI, stroke, it seems that that's the case. But remember, there's a little offset. We have less stroke with PCI, a little bit increased MI with PCI as well. But repeat revascularization clearly favored by bypass surgery. But what's interesting with these observational studies, and that's what we were really getting into, is that they're apples and oranges. I mean, certainly there are patients now in our lab, in your lab, where we don't even consider doing PCI in them. We go bypass surgery as a first approach, and then PCI for other types of patients, and then certain high-risk patients, you never consider bypass surgery.
And I just don't think propensity-matched analyses do right for these analytics and give us the right answer. And so we always need randomized studies. There's a huge one right now, Excel, that we're waiting for, and we're hoping that we can wait until we have real evidence before we start making conclusions about which is superior. So this is where we were having our little discussion, which is good.
That's great.
I think the final thing I would say, too, what's nice about observational studies, though, is it shows that however clinicians select patients, the outcomes with both therapies are really good. What was also interesting, at least in this analysis, is that among the PCI patients, the worst outcomes were seen for incompletely revascularized PCI patients. And that gets back to the way we try to practice medicine. If you're going to do PCI in a high-risk triple vessel disease patient, you really should try to get a surgical result. And if you can't, then don't do PCI. Send the patient to surgery.
That's a good point.